Welcome back to another episode of Menopause Reimagined. Today, I have a huge treat for you ladies because we are talking about hormones, hormone therapy, and the WHI, the Women's Health Initiative study with Dr. Tara Scott, who is a triple board certified OBGYN. She's amazing and one of my absolute go-tos when it comes to hormones and hormone therapy in perimenopause and menopause. But before I bring her in, I'm going to do a quick intro to who I am. My name is Andrea Donsky. I'm a nutritionist for more than 20 years. I'm a menopause educator, a 7-time published menopause researcher, and I'm the co-founder of wearemorphus.com, a company that helps to empower you to take control of your health and symptoms now that you're in perimenopause and menopause. And talking about research, I would love you to please take a moment to fill out our surveys. We now have 15 of them on our website, and we have everything from our symptoms, sleep, stress and anxiety, men's perspective on perimenopause and menopause, women in the workplace, pelvic health, and so many more. So please, your voice matters. Take a moment to fill them out. I put a link to them below. And if you're looking for supplements that are high quality and third-party tested, look no further. We've got you covered at Morphus. You can learn more at wearemorphus.com under the shop button. Today I'm speaking with Dr. Tara Scott, also known as Hormone Guru. She helps people find the cause of their symptoms and get them on a path to optimal health. With over 25 years of experience and 3 board certifications in OBGYN, functional medicine, and integrative medicine, Dr. Scott has helped thousands of patients struggling with hormone issues, including endometriosis, breast cancer, weight gain, and more. She's the founder of Revitalized Medical Group and Hormone Guru Academy, a course to help patients improve their hormone problems themselves. After suffering from infertility and endometriosis, she now helps others achieve the same balance. She recently partnered her practice with Forum Health to take Revitalize to the next level. Dr. Scott has been speaking and educating for over 10 years and has taught doctors her approach in 5 continents. For her expertise, she's been featured on The List TV, Shape, Newsweek, Parents, Authority Magazine, and on numerous podcasts. Now, here's Dr. Tara Scott. Welcome to Menopause Reimagined, Tara.
Thank you. Thanks for having me.
I am excited to have you. I cannot believe you've never actually been on my podcast. We were just saying you've been on, in my summits, but you've never actually been on Menopause Reimagined. So I am happy to have you here. At least I don't think you have.
I don't
So yeah,
know.
okay. I don't think so either. Okay. So to me, you are a guru. You literally, when it comes to hormones and menopause and you practice. So why don't we start a little bit with what your background is, and then we'll go into the whole WHI study.
Yeah, so I've actually been in the space for a long time. I mean,
Mm.
22 years just specializing in hormones. 30, almost 30 in practice. I was
Amazing.
originally trained as an OBGYN, delivering babies and, doing obstetrics and surgery. And then right before the WHI decided to take a little time off because I had 3 little kids at home. And then the WHI came out and I was only doing GYN. I had stopped doing OB for a year. So I had more time with patients. So then patients were coming in right after the WHI, which we'll go over.
Yep.
And there were like no options for them. They were like desperate. They were, so I had a little bit extra time to spend with patients, to listen to them, to try to figure out solutions. And then a friend of mine who I ended up, he's my teaching partner, asked me to go to a course. He was a compounding pharmacist, asked me to go to a course on hormone therapy and kind of I don't know if it was even called functional medicine back then. It was more just hormones. And so once I went to the conference that went back to the physiology and the studies and the data and the science, your mind's just like, so I started just like learning more and more and more, became a certified menopause practitioner in 2006. So
Wow. A
almost
long
20
time.
years. Right, right, right. And so
Yeah.
there's not a whole lot of people who can say 20 years of that. And I've kept that up and I've, just like you, I had one poster a couple years ago at the Menopause Society, but I try, to keep up with the traditional literature. And then in 2010, I started teaching with Dr. Spadell, the pharmacist, all over kind of first United States domestically, and then we've taught in 5 continents to
Wow.
other providers and prescribers, Australia, South Asia, Southeast Asia, Brazil, and Europe. So started teaching other doctors and then decided, once you see the more you know, the less you actually know. The more you learn, the less you know, right?
Yeah.
So went back and got more training in more than just hormones in the at the A4M, which is the American Academy of Anti-Aging and Regenerative and Functional Medicine. So I finished that fellowship and board certification, and then I got to sit for my integrative medicine boards in 2015. So currently, right now,
Amazing.
I'm senior faculty at A4M for all their hormone education and also the women's health course lead for the integrative and functional medicine fellowship through the University of California, Irvine, which is more integrative. So I'm the head of women's health there for that fellowship. So those are my kind of bigger teaching gigs along with some other stuff. So
Absolutely amazing. I mean, I remember when I think I first saw you on TikTok and I'm like, oh my gosh, you were like triple board certified. You were like so brilliant. And I'm like, I wanted to learn from you, which is why I had reached out to you way back when and when we first became friends. And I thought, when it comes to the WHI study, when it comes to hormones, you really are my go-to. So, I would love to understand. So maybe take us back to the WHI study, the Women's Health Initiative study. What happened and then what's happened since? Because I feel like it could be very confusing for a lot of women. I mean, now we know that we're looking at it again in terms of what the actual outcomes were, but I would love you to kind of take us through the history and then kind of into today and where we stand today.
absolutely. Well, let's back up just slightly before that to
Okay.
know that there had been a lot of studies already showing the safety of these medications, right? That particular study, I guess I can say trade names because it's a podcast and not CME, Prempro had been FDA approved, I think, in 1940. And by the 70s, it was a mainstream medicine. And certainly by the 80s, it was probably the number one prescribed medication in the United States. So
Wow.
the reason the Women's Health Initiative was done was not to see if the hormone was safe and to see what risks there are. It was done to get another indication to use it. So the four indications for using hormone therapy, according to the FDA, are moderate to severe vasomotor symptoms. So that's hot flashes or night sweats. If you have premature menopause, which is considered before the age of 45, either surgical or by chemotherapy or just, by yourself spontaneous, the recommendation is absolutely you should take hormone therapy to protect your bones and your heart. The third is something called genitourinary symptoms of menopause or syndrome of menopause, which is vaginal dryness, frequent UTIs, pain with intercourse, getting up at night to pee. And the fourth is prevention of osteoporosis, not the treatment of osteoporosis, but the prevention of osteoporosis. So those were the four reasons. So the makers of Prempro said, hey, we believe we've seen so much data that our product prevents heart disease. So heart disease being the number one killer in women, number two, stroke, number three, lung cancer, number four is breast cancer. If you add up the deaths from two, three, and four, you still won't equal the deaths from heart disease. So it was
Hmm.
intestines, right? We believe
Wow.
our product, we have all the studies showing how estrogen, while it's tragic when a man dies at 40 of a heart attack, we never hear of women unless they're diabetic. You just don't hear of that because there's some protection. So that had been well established as far. There's some protection of estrogen because women don't really have an increased risk till after menopause. So the makers of Prempro wanted the FDA to say, yes, you can use our drug to prevent heart disease. In order
Hmm.
to do that, they had to prove that. So they had to get a cohort of people who either weren't currently on hormone therapy or hadn't really taken a lot of it. So that let the average age to be 63. I've seen 63, 65, somewhere in there as the average age. So think about the risk of heart attacks from 52, average age of menopause, to 63. Huge difference, right? One whole decade. But
Yeah.
that was the average age. So they had two harms. One were people without a uterus that just took Prempro. The second were people with a uterus that took Premarin and Provera. Sorry, Premarin was the estrogen only, and Premarin and Provera or Prempro. So there are 8,000 people that got the drug, 8,000 people that got the placebo. And what they found after 5 years of use, they saw an alarming increased risk of blood clots, either blood clots in your lungs or legs, and also an increased risk of breast cancer. And so when they saw that, before it was reported into our scientific journals, it was on Good Morning America. So like
That is so crazy.
I remember being in the office and getting flooded with phone calls. And I was like, what's the new study about, breast cancer? And we're like, what? What are you talking about? Everyone panicked, go off your hormones, cold turkey, whether you were 40, with no ovaries or 70 still taking it, it didn't matter. Everyone panicked. And we didn't know and I didn't know what I don't know then. So everyone kind of went off and everyone thought hormones are bad. So if you
Mm.
break down, it's something like 8 out of 10,000. And what the menopause position statement says now, as far as the risk of breast cancer for Prempro, it's 3 out of 1,000. For other, and they've come full circle in the last 20 years. There were a lot of position statements, not every year, that were saying first it was like just take it for 5 years, shortest duration, minimal dose, and then they've kind of taken away that time limit. There's currently no age to stop it now, but they do say the benefits of starting it between 50 and 60 or within 10 years of menopause outweigh the risks. The risk
Mhm.
being blood clots if you're choosing to use an oral medication, which I don't ever do. And then breast cancer, we have to tell you it's 1 out of 1,000 if you take a bioidentical regimen, which would be like an estrogen patch and a progesterone pill. So those could be
Right.
generic, FDA approved, get them at Walgreens. I don't know if you guys have Walgreens where you are, but whatever your traditional pharmacy is, right? Not compounded. Those are considered bioidentical. So the study got blown out of proportion also because out of the WHI, there were all these other studies with that same medication. It's an oral estrogen, conjugated equine estrogen. So actually, if you look at what's actually in it, there are multiple, we don't even know it's a proprietary brand, but most of it is estrone or equilin sulfate. So first of all, our body doesn't recognize equilin sulfate, has a 48-hour half-life. And
Mm.
when you break it down, it breaks down more preferentially down a pathway called 4-hydroxy, which is more stimulatory to the breast, okay, compared to estradiol, which is what our body makes. So that's the first issue. The second issue is when you take anything orally, it goes through your liver. And in your liver is where your blood clotting proteins are formed. So there was another study in the British Medical Journal in 2008 by Marianne Canonico as a meta-analysis. There were like something like 15 different studies. Some were randomized placebo-controlled trials, some were observational trials. And what they all said is that oral is what causes the risk of blood clots, not transdermal. And it also
Right.
depends on the progestin used. So that was published in 2008. So then it was pretty clear that it's the oral form, not transdermal, that increases the risk of blood clots. So then the only thing that was really kind of hanging over everyone's head was this breast cancer issue, right? And so in the estrogen only arm, where people choose to take Premarin only, the incidence in placebo of breast cancer was very low. It was something like 0.35%. And the incidence in the people that took the drug, 5,000 people, was 0.27%.
Mm.
That was not statistically different, but because it is a lower percentage by 0.8%, they're calling it a reduction in breast cancer. But there was certainly no increase in risk in estrogen only.
Okay.
Then there's been several studies. There was a big study last year published by Chlamowski. I might be saying it the wrong way, saying that in estrogen only compared to no hormones, there wasn't an increase in risk. Now, there are several observational studies. The E3 EPIC cohort, I know you referred to that. That was an observational study in Europe that was published in 2008. Initially 2005, 50,000 people, then it was extended to 2008. They had 4 groups. One was a control group that took no drug. One was no uterus, so estrogen only, estrogen plus micronized progesterone, estrogen plus progestin. In those women in Europe, ages 40 to 64. They were followed for 8 years. Most of them chose to take a transdermal estrogen. It was like 98%. So it kind of eliminated that variable of the oral and the conjugated
Right.
equine estrogens, right? So what
Mhm.
they found in that cohort is the highest risk, sorry, of breast cancer was the estrogen plus progestin, the transdermal estrogen and the synthetic progestin.
Right.
The people that took estrogen only also had an increased risk of breast cancer. It was a relative risk of 1.3. The people that took transdermal estrogen and micronized progesterone had no increased risk compared to the control group. So as it stands now, there, as far as I know, is no trial of estrogen only compared to estrogen plus progesterone, right? So we're saying that estrogen only is no increased risk compared to no hormones. But what we don't know is estrogen only an increased risk of breast cancer compared to estrogen plus progesterone. That's a whole nother topic. And that my opinion is not necessarily the consensus. I don't give estrogen only, even if you don't have a uterus, because you have
Right.
receptors in your breast. They have progesterone receptors and estrogen receptors. There's quite a bit of data. The Nurses Health Study was another observational study, 122,000 women. And the longer you're on estrogen only, it was something like a 20% to a 35% increased risk of breast cancer.
Mm,
So if you talk to most of our traditional menopause influencers, providers that
yeah.
they will tell you that it's fine to use estrogen only. So that's where my opinion kind of
Mm,
differs based on the science from our textbooks. But the bottom line is out of that cohort came a couple other things like using Prempro increased the risk of stroke and dementia. So up until last week, there has been this black box warning. And every time I wrote a prescription for a patient, even for micronized progesterone in perimenopause, I would have to say, when you get the package insert, it's going to say progestins and it's going to say increase the risk of breast cancer. Your progesterone that I'm prescribing did not do that because it's this, but it's the same category of drug. So that's the black box warning. So if we would write a prescription for vaginal estrogen, you would see that warning, increased risk of stroke and dementia on any estrogen product. And so it was never shown that vaginal estrogen increases the risk of stroke and dementia. And if you look at those studies were on a progestin or oral estrogen, oral synthetic. So there was another recent study published either early this year, late last year, 7 million women on in menopause. So in the States, you get on Medicare when you're 65. I know it's different in Canada. So that's an older age population, and that's 7 million women, and they followed them. Now, the study was done early 2000s, so that meant they were probably on Prempro if they were taking something. They might not have been on bioidentical commercially available hormones. But even in that cohort of 7 million women over 65, there was something like a 26% reduction in all causes of mortality and also a 19% reduction in breast cancer,
wow.
lung cancer, colon cancer. Now, in the people that took oral estrogen, there was a questionable, maybe increased risk of stroke, but not with transdermal estrogen. So I'd have to pull out that paper to tell you all the details of that to get the percentages right. But what that study showed us is that's a huge amount of women, older women who are taking probably a lot of that as synthetic hormones. And we're still seeing a reduction in all causes of death.
So I guess my question would be, why if there's even a doubt when it comes to oral, like, and you were saying you don't really prescribe oral, why do people still take oral estrogen?
So, yeah, part of the reason I don't prescribe it, one is because of the blood clotting risk, but that's only one of the minor reasons. The second is when you take something oral, your body only absorbs 10% of it. So you have to get so much more and you have these huge peaks and troughs. So if you're dosing someone in the morning, by 5 a.m., it's wearing off, right? Because it's
Mm,
metabolized quickly, even if you're using estradiol. And when you give estradiol, your body turns it into estrone in your gut. So your body's getting it as estrone. Estrone has a higher percentage of stimulating breast growth and uterine growth, which we don't really want. We really want estradiol, which is good for your bones and your heart. We don't want more estrone. All of us make estrone in our muscle and fat. And I've yet to meet a woman with not enough estrone, even if you have no ovaries, right?
okay.
So that's the second reason I don't give it because it turns into estrone. The third is erratic dosing, right? Or you're just getting transdermal, you get it more of a continuous. We didn't get a little burst of estrogen from our ovaries once a day when we were younger. You got continuous, right?
Right.
So it mimics normal physiology. But one of the bigger reasons I don't use oral is when you give oral estrogen, it increases sex hormone binding globulin. So it's like your 401k. So now that I'm over 55, I can put more away and I can put more in my HSA. So I'm getting directly from my paycheck into that. And what you're not getting is you're not getting it in your cash, right? So you have the money, but you don't have access to it. So that's what happens to your thyroid hormone and your
Mm.
testosterone. So you have less free testosterone, less free thyroid. So people have symptoms with that.
So can you explain, and I know you alluded to it a couple times, can you explain the difference between micronized progesterone and progestins?
Yes. So progestins were formulated years ago for birth control for the reason of stopping ovulation so you don't ovulate, you don't get pregnant. So what happened when they made Prempro and sorry, Premarin? Initially they gave estrogen only. And after about 10 years, what they saw was there was an increased risk of cancer of the uterus. That's because they're giving estrogen without the balancing form of progesterone. At that time, they didn't know how to micronize progesterone. It's a much larger molecule than estrogen, so they couldn't figure how to put it in a capsule. The technology didn't exist until the late
Hmm.
90s when prometrium or
Interesting.
micronized progesterone came in. So they said, let's give a progestin. Well, guess what? The progestins were more similar to birth control pills. So they knew that it did cause it did prevent hyperplasia in the of the uterine lining, overgrowth of the uterine lining. So that's what that did. So they packaged it together with the Premarin. And so that became standard for hormone therapy. And so even though in men's hormone therapy, it's bioidentical, for thyroid, it's bioidentical, for diabetics, it's bioidentical, for transgender or gender affirming care, it's bioidentical. Women are the only people because oral contraceptives exist. So the two things
Oh.
are different. So I explain it to this way. Let's just say you had a diabetic patient who was about to pass out because they had a really low blood sugar. Would you give them Splenda?
Hmm.
Splenda has 0 calories. Splenda can sweeten your coffee, but it has zero glucose in it. So your brain needs glucose to fuel. So by
Hmm.
giving someone Splenda, you're not giving them anything. You're just kind of sweetening their coffee.
Right.
Progestin has actions. It's kind of like the valet key to your car. It'll do certain things, but it won't do everything, right? That's
Hmm.
what the progestin does. It fits differently in the receptor. It agonizes it differently. So what does it do? It protects the lining of the uterus, but it causes more breast tenderness generally. Now we're seeing another article that just came out with birth control pills increasing the risk of breast cancer, IUDs increasing the risk of breast cancer. So it has does the opposite in the breast. So it's kind of like we have diamonds, cubic zirconiums, and now we have lab created diamonds. So lab created diamond would be like micronized progesterone that's made in a lab like a diamond that exists. So you have your hormones that our body makes, which are the natural diamonds. You have the lab created diamonds that are real diamonds that are made structurally identical to like what we make. And then you have cubic zirconiums that look like it, function like it, but aren't really a diamond.
Hmm. It's interesting that you're mentioning, so you're talking about birth control, you mentioned IUDs, and so progestins are what is in those products. So why are birth control pills and like why is that prescribed to women? Because I've heard a lot of again, I always say I'm not an expert in hormones. I turn to people like you, I turn to people like Dr. Lakeisha. Like I'm like, so why are women being told to take birth control pills to help manage their hormones?
Because I can tell you, I'm a traditionally trained OBGYN. We have no training in hormones. We have a 3-month reproductive endocrinology rotation in our third year of residency that we learn how to get someone pregnant. We learn how to prescribe fertility drugs. We learn about all that. We learn about contraception. We learn nothing about menopause.
Mm,
Zero. So we're told when someone comes with irregular periods, rule out tumor, rule out endometrial hyperplasia, and then give them birth control pill. It's an algorithm. You're
oh,
not taught any other way. I was not taught that a progestin is not progesterone in residency. So these women are going to who they think are going to help them. They're
mm,
OBGYN, right? And some OBGYNs are very open and they're more open and like, I don't know anything about hormones. But back then they'd be like, take the pill, take the pill. You know what I mean? Because that's the end all be all for everything. But it's not replacing your hormones. It's putting you into a false cycle, giving you withdrawal bleed. Sometimes it helps some of your symptoms because it does fit kind of in the receptor. It's like if you put a square in a circle, it kind of can fit, but it doesn't do everything it's supposed to do.
hmm. And then same thing with an IUD. It's interesting about IUDs, and this is outside of perimenopause and menopause, but my daughter was, when she was looking at birth control, she didn't want to go on the pill and she had opted for the IUD route and it was a progestin IUD and it gave her insane headaches. Like she had to have it removed very quickly after.
Wow, I wonder if that's like your intolerance to hormones too, so it could be
Hmm.
that. And so I do see that with a lot of people. And back then we would have thought, oh, it's not because of the IUD, it's not systemic. It absolutely is systemic. There was a study published at the Radiological Society. It's called the RSNA, and they did a study that they looked at women's MRIs before they had IUDs inserted, and then
Hmm.
they had MRIs after they had IUDs inserted, and they saw that there was a difference in breast density equaling an increased risk of breast cancer. They also
Wow.
saw the opposite. People who had IUDs in had a certain breast density. Take the IUD out, breast density reverted. They
Mm.
published that. It was a couple years ago. I have that
Wow.
somewhere too, that article somewhere. And so they published that showing that actually the IUD in your uterus is systemic. It's not just in the uterus. We're told by the manufacturer as a OBGYN, oh, it just goes to the uterus. So that's a concern as well because that levonorgestrel is one of the progestins that showed an increased risk of breast cancer. So
Hmm.
again, if you had to ask me, would I want someone to now contraception is a whole different stuff. I mean, when I start to say stuff like this, people attack me and say, well, people need birth control. Exactly. If you want to prevent pregnancy, go take some birth control, right? But if you want to prevent menopausal symptoms, don't take birth control. If you're a teen with acne, don't take birth control if you're not sexually active. That's what I'm saying. I'm not saying don't take birth control. And I'm not trying to scare people from taking birth control. If you want to prevent pregnancy and you know that you're going to prevent pregnancy, let's say for 10 years, then when you're a teen, why would you say take your 10 years if, let's say, that was the statute of risk, right? Why would you put a 14-year-old on birth control for irregular periods and then
Right.
she's not even remotely ready to have babies? So why not do something else? That's what I'm saying.
No, and I think that's very clear. I mean, we're talking about treating symptoms. We're talking about perimenopause and menopause and what's benefit. I hear what you're saying, and that's good that you said that because we definitely don't want anyone attacking you because the whole point is
Right.
that we're trying to provide proper information.
Well, and a lot of people in perimenopause have had their tubes tied or their husbands have had a vasectomy.
Yeah,
They
exactly.
do not need birth control. Now, there are some that still need birth control. That's a different
Yeah,
conversation. The
totally different.
conversation is if you don't need birth control and
Yeah.
you're having symptoms, what to do.
But there's also other forms of birth control as well. So if it's something like, and this is where that's a broader conversation around the birth control pill. But, to me, if it's a concern and you're concerned about the progestins, there are other forms of birth control other forms of birth control that you can look at.
Right.
Okay, let's talk about, you mentioned systemic. So you're talking about like, does it stay local? Does it go systemic? Let's talk about vaginal estrogen because I feel like there's also a lot of information around that where women are, you know, they're worried about taking vaginal estrogen that it won't stay localized. Is it localized? Like talk a little bit about that and the benefits of it.
Sure. So remember, I trained with a pharmacist. So I'm always looking at stuff pharmacologically and absorption. Absorption, it's like ADME, it's absorption, distribution, blah, blah, blah. They have the whole thing.
Yeah.
Vaginal estrogen is absorbed, right? It's thought of as local therapy. And I think because we usually pulse it, we do it every day for 14 days and then twice a week. And the studies have shown that when you give vaginal estrogen, it doesn't cause endometrial hyperplasia, so you don't need to give a progestin with it. However, vaginal hormones, if you put them high in the vagina, there's all these blood vessels right outside the uterus that can pick it up and go take it systemically. So back in my early days as an OBGYN, I remember prescribing vaginal estrogen and someone saying, "Oh my gosh, I had so much breast tenderness." And I remember thinking, "Really?" Well, I was wrong, right?
Mm,
Yes, she did absorb it and had a symptom with it. So either she was very sensitive to estrogen levels, she maybe had poor estrogen detox that it accumulated. But
right.
that particular patient, she did. There's other protocols out there for people I've seen in my 22 years that some people like labial administration of hormones for systemic. I'm not a fan of that, but there are some people who prescribe it that way. So if you're putting it on the labia, that's absolutely, they're treating it as systemic. It's a little bit harder to monitor and quantify when you're doing it that way, but I don't think we should, it is considered local. I don't think we should broadly say it's not systemic. But what we don't have is when you give vaginal estrogen, we don't have studies on does it help the bone? Does it help the heart? Does it help the brain? We don't have those studies and what happens to the breast. So we can say it's local. So I don't know that I would rely on that method of administration for those other benefits.
And it's interesting that you said that because my next question was going to be, can somebody safely take vaginal estrogen with their regular hormones?
Yeah, and so that's not duplication of therapy. So if you think about it, if you had a thyroid issue and you had really dry skin, you would continue using hand lotion until your thyroid was right, and then you might not use the hand lotion anymore. So a lot of our patients, when they come in and they have really bad GSM and they need vaginal estrogen and they choose to take systemic therapy, then when the systemic levels get to be where they are, they may not
Mm,
need the vaginal hormones anymore. So you can take it both. It's not a contraindication.
okay, that was that's a
The only thing about the vaginal hormones, the only caveat is with breast cancer patients, again, the FDA removed the warning label on vaginal preparations and on all hormones last week. And so breast cancer patients, generally, it's safe to use estrogen products in the vagina. However, there was one study that showed that people who were on aromatase inhibitors had a slightly increased risk of recurrence.
mm,
So my preference for breast cancer survivors is DHEA. DHEA does not aromatize in the uterus to estrogen. That enzyme doesn't exist there, and it doesn't in the breast either. So for those patients that are on aromatase inhibitors, that's what I would prefer. We do have an FDA approved in the States, DHEA vaginal option.
It's funny. You're going exactly why I wanted to go. So I love this. So DHEA, I wanted to talk about it for a minute because as you mentioned before, I didn't do well being on estrogen. And it's funny enough, even with micronized progesterone, I was on the 100 milligram oral and my boobs were on fire. But I had been on progesterone cream for years and years. I mean, I used it for fertility because I had PCOS and I was probably on it for, I don't know, over 10 years for sure, for a long time. And I had no issues. But when I took it as a pill, I couldn't do it and I had to come off it. And I was taking it with estrogen at the time and I had to come off it because my boobs were on fire. So let's just talk about that for a second. And then I want to talk about DHA.
So oral micronized progesterone is um, it has a very short half-life, about 6 hours. And when people metabolize it, there's two pathways down, the alpha and the beta pathway. And so even if you have a certain predisposition to it's the same enzyme that metabolizes testosterone. But even if you
Mm.
have, what's interesting, some people can go down the alpha pathway for testosterone, but the beta for progesterone. So actually, Carrie Jones does a really great job with this, and I don't want to tell you which is which, but probably what happened is you went down one of the progesterone pathways selectively and you got a lot of those symptoms. That's the first thing that could happen. The second thing could happen is that you were probably taking a commercially available micronized progesterone because Canadian healthcare. And if you watered your plant with all the water for the week, what would happen? Your body could only absorb so much and then it'd run out and you'd have side effects. Versus if you got a little bit a day, you might do better. So the topical progesterone cream might have been micronized a little bit better, might have been a slower onset,
Yeah.
slow. So a lot of my patients that have that symptom do much better with a compounded version, a different dose. It could be the ratio of estrogen and progesterone, and they seem to do better. Very rarely do I have a patient that can't tolerate progesterone. I have had a few, but it's not very common, and usually they do better with the topical.
Yeah. It was no
Troche,
issue for me for years.
yeah, a troche too, which is a sublingual. So there's
Mm.
a couple of different options.
Okay, so let's go back to DHA for a second. So DHA, explain what it is and then explain how it works with hormones. Like why would somebody, so you were talking about with women who have had breast cancer, but are there other women that should be doing it? Is something you may want to consider instead of estrogen and progesterone? Talk a little bit
Yeah.
about.
So DHEA is adrenal hormone made primarily in your adrenal glands. So I explain it to my patients like this. Imagine that your estrogen, your progesterone are your monthly paycheck, right? And when you retire, you're going to live off your 401k. your savings account. Your savings account is your adrenal gland. So when you go through menopause, your adrenal gland provides the precursors of DHEA. And through androstenediol or androstenedione, it converts either to testosterone or an estrogen product. It does that within the cell in something called intrachronology, which means it'll get into the cell. And depending on what type of cell it is, we talked about the breast and the uterus not having aromatase, so it would turn into a testosterone compound. It would have its action, and then it would be inactivated within that cell and excreted as a metabolite. What does that mean? Say someone comes, this is like a bad, people get it, right? Say someone comes to my house, they smoke a joint, they put it out, and they leave my house. You never see the joint, right? You never see what happened. You never see the smoke. It had the action within my house, and then when they leave, it never affects anybody else. Nobody can smell the pot, right?
Mhm.
So that's what happens to DHA. A lot of the data on DHA was done by another Canadian, Dr. LeBray, who is no longer with us, but I did a ton of research about it. And whenever you bring a drug to market, you have to do all those FDA trials for safety, efficacy, that kind of thing. So he did quite a bit of trials on an oral form of DHEA as well, which is not commercially available in the States or Canada. As a matter of fact, in Canada, it has to be regulated like a narcotic, but here you can just get it over the counter like
Yeah, you can go to Whole Foods and buy it. And it's
I
not expensive, which is interesting
know,
too.
which it
I mean,
should
at
be.
least you used to be able to. I don't know if you still can
Yes, you
now
still
and things have
can.
changed, but
You still can. You can go put yourself
okay.
at 100 milligrams, which is too much for a woman. But so it's really a great, safe option. And there's not that many people that I've had that haven't been able to take it. So I've been using that in my practice 20 plus years as well before it was commercially available. A lot of safety data on it and studies about the
Yeah.
endocrinology of it. So I have also given it to patients who are breast cancer survivors, especially those who have had bilateral mastectomies. They don't have breasts, right? And have good prognosis, but nobody will let them take estrogen, right? So it's a good therapeutic option. It does turn into testosterone also. It's a precursor, and a lot of women are really needing that as a hormone because stress depletes that. And now, after the pandemic, so many people are having really low levels of androgens. So I feel super comfortable using it, and it's a regular part of our regimen.
I love it actually. I take it and I take it with a little bit of pregnenolone. Like I take a brand that has pregnenolone. But I'd read somewhere, and I'd love you to actually clear this up, that pregnenolone can convert to progesterone in the body, right? So that's what I've had blood tests done. And is it the pregnenolone or the DHA? Because I take the DHA with the pregnenolone, and I have my blood tested, and my progesterone is beautiful, right in the right range.
So pregnenolone has a very, very short half-life also, and you don't know which way it's going to go. Pregnenolone can turn into DHEA or progesterone, but DHEA can't turn into progesterone. DHEA is what we call downstream. It's
Hmm.
past that. So it can't go back to
Hmm.
make progesterone. But pregnenolone is above everything. It's like right under cholesterol. So it can
Mother hormone.
cortisol. Yeah, it can turn into cortisol. It can turn in, we don't really know. And actually, if you look at the anatomy of the adrenal gland, there are different zones. Progesterone really can't turn into everything out. Like there's different zones of the adrenal gland. They don't go sideways. It's not one dimensional, right?
Yeah.
So, but pregnenolone, I think is another great therapeutic option for some people. It can turn into progesterone. I don't know that you can, I mean, I guess in you're saying you can measure the levels. Um, it's such a short half-life in that conversion, so I don't know. Even with progesterone levels are really hard to measure anyway. So that would be something that we can measure. I don't think you can measure in Canada, at least when I talk to providers there. We can get a pregnenolone level in the blood. And so it's a great option for people who are intolerant to other hormones as well.
So I guess like what you're saying, because I had read, and I didn't know how true this was, is that I had read that pregnenolone um, could be related or could be connected to breast cancer, but could that just be based on how it converts in the body? Like I'm wondering if is that something that I had read, if it was a study that I had read or something that I had read a little while ago, and I kind of stuck
I'd
with me when I
be
read it.
really interested in looking at that design of that
Okay.
study because also what pregnenolone turns into is cortisol. And there's absolutely a
Mhm.
connection between cortisol and breast cancer
Hmm.
and any cancer. So I don't know that it's actually the pregnenolone or it's the cortisol.
Yeah, so maybe what it converts into. Interesting. It's so fascinating. Like I find, and it's like for me, because I'm not an expert in it, I find hormones so complicated and I love learning about it. And like I know a little bit, but I find it's super fascinating. And then genetics play a role too. So like you've been talking, so do you in your practice, do you test people's genetics so that you know what you're kind of dealing with as the foundation?
So for breast cancer patients, we look at their genomics of their estrogen detoxification. I mean, that test still is a little bit costly in the United States. So it's really going to depend on the patient's resources. I mean, some people are doing the genomics of their estrogen detox pathways, which is really helpful. Their MTHFR, their COMT, 1B1, their cytochrome 1A1, all that. But it's not, I mean, I still kind of practice in middle America where people are like rationing what money they have for the hormones and the tests and everything like that. So I wouldn't say that we test all of our patients.
Mm-hmm.
Remember, we in the States have to pay for sometimes blood testing in labs. So a lot of
Yeah,
that is out of pocket. So, and
sure.
like all my hormones are not, I have a high deductible. I have to pay out of pocket for my hormones because I'll never reach my deductible, even though I have insurance that I pay for every month. So there's different varies of it. So yes, I love when I can, especially in anybody, but remember, genetics is just I can't, what's the saying? Genetics loads the gun and epigenetics pulls the trigger. So I know
Mm.
I have a slow compt. I know I have my genetics are not good for breast cancer, so I would be at increased risk based on my genomics. But I know that like all the other stuff, the lifestyle, the monitoring of the hormones, the getting everything, everything else, the pesticides, the environmental toxins, endocrine disruptors, everything else that I work on, I'm not that concerned about it. Not that I'm not blind to it, but so there's a lot that goes into that. We do love when we have that information for patients, but we don't always get to have that.
And I also know that are you still on the board or you're working with the Dutch company? Like I know when it comes to testing, like so looking at methylation and looking at certain things, which I do believe and I think from what I understand is that it's looking at like when you get the urine test or you do any type of those 24-hour tests, it'll tell you like even though your genetics, let's say they'll say you don't methylate well and you shoot your E1, your estrone into 416 OH as opposed to the 2 you kind of mentioned a little bit before about the 4 not being favorable for the breast. But in when you're actually getting, let's say, a Dutch test or another type of metabolite test, it actually might not be the case in real life. So to your point, it might be worthwhile more to do something like the urine testing or another type of testing that can give you what's happening in real life in that, in your daily
Right.
like,
I know I've had people, and I don't have any professional affiliation with the Dutch test, but I do speak for them on
oh,
occasion.
okay.
So, and I use their test. There's also another great test called from Vibrant that does the
I
urine
love vibrant
metabolism
wellness.
and
Yes.
does the endocrine disruptors. Have you seen the
Yes.
hormone zoomer? So what it's doing is it's looking for parabens, phthalates, all that stuff in your urine with your urine metabolite. So perfect for endocrine disruptors. So I thought I was so good. I did my test last summer because they launched it and they wanted me to help do some boot camps for them. I'm like, oh, I've detoxed. I've gotten rid of my plastic, overhauled my makeup. And I came back high with atrazine, which is the one that's on golf courses. And I golfed a lot when I was a teenager. I didn't golf for like 20 years, and I golfed once a week from July to October last year. And my atrazine
Wow.
came back high. I'm like, are you kidding me? And then something else came back like like everything else was okay, but there was one other thing that came back kind of borderline, like it was not high, but it was borderline. So I love that test also. So that is also like the dried urine test in the sense that it does estrogen metabolites. So I love the Dutch test for estrogen metabolites and cortisol. The Vibrant test does that also, but adds on the endocrine disruptors. A little bit different. It's a new kid on the block, so yet to see, like validity and compare and everything like that. The dried urine's been around for a little bit longer. ZRT also has a dried urine test as well, where they look at BPA on their test, I think. BPA, they look at a couple things. They don't look at everything. So three options that I trust for urine metabolite testing.
I actually interviewed Dr. Aaron Gonshore. He is from Fluids IQ. I don't know if you're familiar with that company. So yeah, that's another company, and I'll actually link to it below. And I'm happy to make an intro. It's very interesting too. Like he talks a lot about the different types of testing, and he does like the urine, and he does I would say called fresh urine, not dried urine. I don't know how you actually.
Yeah, vibrant is like a urine vial,
Yeah.
but spot urine, Dutch and ZRT are dried urine. So ZRT, it was actually one of the ones that actually developed that technology,
Oh,
and then
wow.
yeah, and then Dutch broke off, and then vibrant, it's a vial of urine. So I don't know about the other one, but there's a couple more on. There's another one that I think by Diagnostics that's called the HU map. I haven't tried them. So there's some other options
Yeah.
to it, but you're right. I think that's meaningful information. If you have the genomics, it's also helpful, but from a protection, getting those endocrine disruptors is also good.
Oh my gosh, totally. Yeah, it's very interesting about you that you mentioned vibrant wellness because I talk about I mention them in my book because they're testing. I just find it and they have such a wide range. I thought
Huge
they were
range. They
cool.
have a lot. And I'm
Yeah.
working with them a lot, and they really are,
Cool.
pro education for providers and everything, which is great.
Yeah, I think they're super cool. Okay, so as we're coming to the end of the interview, I just want to ask you one more question, and then I'm going to ask you to kind of like if there's anything we didn't talk about. But I want to talk about women who have had cancer. And I know you talked about the breast cancer, but I see women ask this question all the time or say that they'll reach out to me because we have a supplement company. We don't deal with hormones. They'll say, I can't take hormones or my doctor didn't let me. So can you talk a little bit about who should not be taking hormones, and just for the women who aren't on it, who don't want to, well, actually, I guess that's two different questions. One is for the women who have had cancer or other diseases who are told they can't. And then the other one is if they don't want to take hormones or they're not or they can't, what are some options for them other
So,
than DHEA, which we talked
yeah,
about?
according to the menopause position statement in 2022, the only thing it says in that paper that cannot take hormones is end stage poorly differentiated uterine cancer. And then there is one, and I just went over this in the lecture yesterday, and I'm blanking on it. I think it's called endometrioid type of cancer, which is one type of ovarian cancer that's very specific. It's called endometrioid, I believe. But listen, those are the only ones that it says you cannot take hormones. Under breast cancer, it never says if you have a first degree relative, don't take hormones. It doesn't say if you have breast cancer, never take hormones. What it says is breast cancer survivors taking systemic hormone therapy is generally not advised unless you have severe disruptive vasomotor symptoms that are unrelenting to other non-hormonal therapy in the conjunction and shared decision making with your oncologist. So it never says there, don't ever give somebody whose mom has breast cancer hormones. It never says that. It doesn't say ovarian cancer, it doesn't say cervical cancer. The ones that we know that are sensitive to hormones are breast, uterine, melanoma, and then this one ovarian cancer that is endometrioid. So those are the only cancers.
Mm.
And I have patients who have a history of melanoma who are safely taking estrogen. Again, it depends. So really the only person that I wouldn't right away prescribe hormone therapy is someone who within a few years, we try to get them 5 years, has had breast cancer. Obviously, if someone's actively undergoing therapy, or they're within 5 years of their treatment and diagnosis of breast cancer. We just want to get them a little bit farther out. We want to weigh the pros and cons. We want to understand what's going on in their body with their estrogen detox, their tumor, and everything. So there's generally something that's causing estrogen to be greater than progesterone, unless they're triple negative. It even says in that position statement, if you have BRCA1 and BRCA2 and you have had your ovaries removed before the age of 45, you should take hormones until the age of 52. So having BRCA is not a reason that you can't take hormones. And it
Mhm.
doesn't say if you've had a prophylactic mastectomy. It says if you've had a prophylactic oophorectomy, ovaries removed. So it doesn't even quantify that you have to also have had your breast removed. You can have your breast and you should take hormone therapy if you've had your ovaries removed. So it gets really blown out of proportion as far as who can and can't take hormones. Cancer of any other kind, colon cancer, there's less colon cancer in the WHI, there's no correlation to other types of cancer, and that's not a universal contraindication.
And then what are your thoughts on the new medication? So for, let's say, so obviously I'm a big believer in supplements, and I know you are too, in terms of you with, on the like in synergistically with hormones. I know that you believe in both. And I'm a huge fan of supplements, which is why I launched a supplement company, but the right supplements. I don't think we should be taking everything and anything, like anything, right? It's all about taking what your body needs. So what are your thoughts though on the new medications that are out there?
There's one that's definitely FDA approved, and there's another one that
The
might
newer one that was just approved
pathway,
recently.
yes. And so those are neurokinin and bradykinin receptor, working through the receptor in the brain. So while it may help hot flashes, and I think one of them also had a reduction in sleep disturbances, but I haven't seen any data that it protects your heart, protects your bone, helps for moods, or any of the other things that we've shown that hormones do. But for hot flashes, it can help. But there's so much more than just hot flashes, right? With
Oh,
men.
103.
It could say the energy, the sleep disruption,
Like so
the
many.
mood changes are you've done the research on the how many symptoms there are.
Yeah.
But I wouldn't say hot flashes is the main one I hear from patients. It's
Number
certainly
10. Is
thing.
it so
Yeah.
on the list of 103, hot flashes coming at number 10. Number
What are
one,
the first couple?
fatigue, brain
Yeah.
fog, sleep.
Yep, I would agree. That's what I see in my practice. It's
Yeah.
not hot flashes. And so
No.
to have a medication that you can take for hot flashes is great, but what about those people that have those other symptoms?
And then there's also supplements that you could take for hot flashes, but I know that's another route, right? So hot flashes versus medication is totally different. But yeah, no, it's number three. And then you've got, other things like joint pain and anxiety, and the list
Ah,
goes on and on.
yeah,
But
right.
but definitely there's a lot. Well, Tara, this has been amazing. I just adore you. You know that. And
Mhm.
thank you for being such a huge support for my book and answering questions and being a part of it. So thank you for that as well. I appreciate you. Is there anything that you'd want to share with our listeners that we didn't cover? I know we covered a lot, but anything that you would like to leave them with or share that you haven't yet?
Gosh, in a parting comment, it's so hard. We didn't even get into testing to test or not to test. But basically,
That's right. Actually, you're right. Whether or not we should test her. I know you're a really big
I'm a
believer
tester,
in
yeah.
testing. Yeah, I know that.
And I just got back from teaching doctors in Australia, and they said, no, they have to test. It's not controversial to test, to do blood testing
I
there.
love that. Yes, I agree. I'm a
Yeah.
huge believer
And
in testing.
so, I guess is hormone therapy right for everyone? Not necessarily, but what I believe 100% of women deserve is to have a complete, history review system, family history, past medical history, an assessment on their symptoms, and they deserve to be told what are the risks and benefits of hormone therapy that pertain to them so they can weigh the pros and cons. So should everyone take it? Not necessarily, but everyone deserves to find out for them. So when you're going to a provider and the provider's saying, I don't believe in HRT. I mean, I've been told that patients say that, and I say, well, the provider doesn't have to take it then. That doesn't mean they have to decide for you, right?
Yeah.
So each woman should be given an objective assessment on their medical history and hormone levels and decide what's best for them. That's what I hope for, is that access to care. There's a lot of stuff popping up in the US. I'm currently working with LifeMD, which is a telemedicine company, 50 states, which is great, trying to get access to people, to providers, doing it the right way. Some are just going by history and prescribing hormones. Some are testing. So that's why I'm glad to be able to make sure that there's a testing option for LifeMD patients. I just wish that everybody would be able to get an objective assessment and not just think, like you said, I have cancer, I can't take it, or my mom had cancer. I hear that all the time.
Yeah. Shift
Endometriosis is the other
sometimes.
thing. I have endometriosis, I can't take it. It doesn't say that at all in the position statement. So,
Yeah. Well, thank you so much for doing this today.
yeah, thanks for all the work that you've done for menopause and spreading awareness as well.
I hope you enjoyed my interview with Tara as much as I did. She is amazing, so smart, triple board certified, and a menopause expert. So if you enjoyed it, please share it, because the more you share shows you care. And now you know so much more about hormones, as do I. If you enjoyed today's interview, please rate and review our podcast so more women can hear from our incredible experts. And please take a moment to leave a comment. I know there's a lot you could be doing, but instead you chose to spend your time with me. And for that, I'm grateful. I'll see you at the next interview.